Assalamu alaikum. My name is Dr. Aashar Jamelle, and I am head of department at Sir Syed, associate professor in periodontology. Today, I'll be talking a bit about endo-perio lesions and just diving into it. We'll be starting off with a little bit of history and a definition of what it is. So defining it is a pathological communication between the pulp and the periodontal tissue within a tooth. So what essentially it is that there are some communications which can happen and uh, between the pulp and the periodontium. And so there are two ways where these pathways, these communications can happen. There's anatomical, which is the normal physiological ways where you can have a communication between the pulp and the periodontium. So you have, so this could be via the apical foraminers or lateral and accessory canals and the dentinal tubules. So that is a physiological way. Then non-physiological, which is could be more or less pathological, could be due to root perforations where while doing a root canal, this could happen, or if there's some certain trauma, and with this trauma, whichever trauma, it can also take place or caries. So all of this, what happens is essentially these can have a communication which is pathological. So this is how these both the pulp and the periodontium can communicate. So going a bit historic about classification. So the classification, it was first classified in 1972 by Simon. So Simon Glick et al., they spoke about first that it starts off with their primary endodontic lesions, which, is just like only focused on where the only the pulp is involved. Then there's primary endodontic with secondary periodontal involvement, where from the pulp also you have periodontal involvement as well. And then there was primary periodontal lesions, which where it's only the periodontal disease, which is to do with the periodontium was involved, and bone loss and all of that attachment loss was taking place. Then there was primary lesions with secondary involvement, and then there's true combined lesions. So true combined lesion is where you have both happening at the same time. You have the endodontic lesion and periodontal disease, and they're both uh, taking place at the same time, and they're separate and they don't have any link together. In 1999, the next classification had come by Armitage, and he made it. His classification was that there's endo-perio lesions where you have where from the channels which are there, which we spoke about, the apical foramen, lateral and accessory canals, dental tubules. So you can have from the endo, the classification said from the root canals You can have the links between endo and perio lesions. That was the first one. So you can have it physiological or non-physiological. And then the second was perio-endo lesions, where you can also have the same link, physiological and non-physiological, meaning apical foramen, lateral accessory canals, or non-physiological iatrogenic perforations. Um, so they were interchangeable, where these communications were there. The last is combined lesion, where again these diseases are taking place, but they're taking place separate, and the progression is separate. So that's how they went about. And so what in 2017, so Herrera, one of his studies has said that the an established endo-perio lesion is varying degrees of microbial contamination of the dental pulp and supporting periodontal tissues. And nonetheless, the primary etiology of these lesions might be associated with endodontic and or periodontal infections or trauma or iatrogenic factors. So they just said that they both, there is a lot of microbes which are together, and they can be seen both because there is a varying thing seen in the pulp and also the periodontal disease. And these things had this etiology taking place, and these infections uh, were, when this happened, this was going to progress the disease. And so moving on to uh, where the latest classification. So again, the latest classification is talking primarily about endoperiolesions lesions with root damage in the first. So this is what components do they have? There's root fracture or cracking, there's root canal or pulp chamber perforation, and there's external root resorption. So in this, there is a root damage in the first component of this in the classification. So whenever there is a root damage, there can be root damage because of perforation, which is when, as I had spoken before, there are channels which are where you have non-physiologic, where a patient, where a doctor can cause perforation, or external root resorption can take place because of various reasons, or there's a crack. So then you would have, this was divided into endoperiolesions lesions with root damage. So this is going back to how they had spoken about, where there was, so this was non-physiologic ways where there was a the communication. And then the next which was there was endoperiolesions lesions without root damage. So that had this was that the root hasn't been damaged, there's no cracks, there's no perforation. And in this, they had the classification was endoperiolesions lesions in periodontitis patients. So in this, they had where in a periodontitis patient, if you have these lesions, you would see that grade 1 was there was a narrow, deep periodontal pocket in one tooth surface. Grade 2 is a wide, deep periodontal pocket in one tooth surface. Grade 3 is a deep periodontal pocket in more than one tooth surface. So if you see, the words are a little different here, narrow, deep, and then wide, deep. So this was how it is varying in different grades. And the other one is endoperiolesions lesions in non-periodontal patients, periodontitis patients. So this is without periodontal disease. And so you have different ways. You have grade 1, where there's narrow, deep periodontal pocket in one tooth surface. Grade 2, wide, deep periodontal pockets in one tooth surface, and grade 3 is uh, deep periodontal pockets in more than one tooth surface. So the grades are similar of both, but one is in periodontitis patients and one is without periodontitis patients. So how is this different from what in the Armitage 1990 classification is that it's a single category entitled combined periodontal lesions. So they have made it a single thing where you have physiological or non-physiological the um, the channels which are there. So these things are taking place. The combinations of them, as I said, perforations, this, that. So they are all have been combined together, and it's reflected the clinical condition of the lesion, thereby overcoming the problem of using history of disease as the main criteria. So it tells exactly the good thing. It tells what the current condition of the lesion is. So that was the advantage of the 2017, which is the latest one. So the mechanism of effect, there's pulp effects on periodontium effects on pulp, and the joint lesion. So this is how uh, endoperio lesions are affecting. And you can have the clinical presentation can be rapid onset, rapid destruction of periodontal tissue, underscoring the importance of prompt treatment, pain or discomfort, prompting patients to seek urgent care. Can be endoperio lesions, may also occur in acute or chronic form and have different symptoms. The primary signs associated with these lesions are deep periodontal pockets extended to the root apex or negative altered response to pulp vitality testing. So other signs and symptoms may be radiographic signs of bone loss in the apical or furcation region, spontaneous pain or pain on palpation, percussion, purulent exudate suppuration, tooth mobility, and sinus tract fistula, and crown and or gingival color alterations. So signs observed in endoperio lesions associated with traumatic and or iatrogenic effects drastically impair the prognosis of the involved teeth. This may include root perforation, fracture, cracking, external root resorption. So how you manage it? Extraoral examination, fever, lymph, swelling, lymph nodes is checked. Then you have history, that is trauma and pain history, previous treatment. Then intraoral, you need to see the perio screening. You probe around the teeth, swelling, sinus suppuration, mobility, percussion, furcation, and grooves, sign of perforation or grooves, occlusion, and then you also check occlusal trauma. You also check tooth um, the sensibility, which is hot cold tests and radiographs. And then the main prognostic groups for tooth with endoperio lesions are hopeless, poor, or favorable. So hopeless mostly are the ones with perforations and all that. So those come under that. Hopeless is normally associated with endoperio lesions caused by trauma or iatrogenic factors, whereas the prognosis of a tooth with an EPL, the endoperio lesion associated with endo and periodontal infections may range from favorable to hopeless, depending on the extension of the periodontal destruction around the affected tooth and the presence and severity of the periodontal disease affecting the patient's oral hygiene. So management depends on the vitality and type and extent of the periodontal defect. Occlusal trauma should be eliminated to reduce risk of further periodontal damage with reduction of splinting. Primary endo treat with endodontic treatment, 3 months review for periodontal involvement, and then perio treatment if necessary. This allows sufficient time for initial healing and assessment of periodontal condition. Primary perio or combined requires both endodontic and periodontal treatment. Non-surgical management of endoperio lesions should be undertaken as a primary course of treatment. The response to the primary course of treatment should be reviewed and a decision made as to whether to would benefit from a surgical approach following the failure to achieve resolution. So this is how briefly I have spoken about endoperio lesions, and this is something which is important and it's new, and we should start using this in clinical practice. And this is which how they've implemented it. So I feel uh, it's a big honor to give this lecture, and I'm hoping that maybe I would also be coming again for workshops, which I've been doing in Islamabad and various other cities soon. So thank you very much, and so this I hope that this has benefited. Thank you.